seen. So the dentigerous cyst is the most common cyst, which the term was given by Pager in 1963. Cyst which encloses the crown of an unerupted tooth by expansion of its follicle and it is attached to the neck of the tooth. That is the dentigerous cyst as defined by Shears in 1983. The etiology is developmental in origin, and it is considered to arise by the accumulation of fluid between the reduced enamel epithelium and the crown of an unerupted tooth or an impacted tooth. The eruptive forces in the tooth causes changes in the vascular hydrodynamics, which results in separation of reduced enamel epithelium from the crown, and there is fluid accumulation between these two. That is the reduced enamel epithelium and the crown. The basis of observation at operation and the histological examination distinguishes the two types, that is the standard dentigerous cyst or extrafollicular variety of the dentigerous cyst. Clinical features include it is the second most common cyst and it is seen in the first and third decade of the life. Mandibular third molar are the most commonly involved tooth, followed by maxillary canine, and this is followed by maxillary third molars. Males are more affected as compared to females, and they are capable of becoming aggressive lesions if they're not treated in time and diagnosed in time. Then initially the cyst is asymptomatic unless it becomes very enlarged or it gets infected, then it becomes painful. Expansion of the bone will be seen and obliteration of the vestibule is seen. Facial asymmetry will be noticed. Displacement of the root and resorption of the adjacent root of the teeth, the root of the adjacent teeth will be seen, and in cases of secondary infection pain may occur. The radiographic feature of the dentigerous cyst shows unilocular, well-defined radiolucency with sclerotic margin around the crown of an unerupted tooth. The radiographic varieties or types of the dentigerous cyst include circumferential cyst, lateral cyst, and paradental cyst. Circumferential cyst is cyst that is attached to the CJ of the tooth, and it encloses the crown of the tooth uniformly on both the sides. Lateral cyst is the one which is attached to the CAJ, but it is more on one side as compared to the other side. And paradental cyst is the one in which the cyst is, although it is attached to the CAJ of the tooth, but it seems that the entire tooth is the cyst is involving the entire tooth. So as you can see in this radiograph, the cystic lesion is seen to be attached to the tooth at the CEJ, and the crown of the cyst is encircled by the cystic lining. The cystic content include yellowish straw-colored fluid rich in cholesterol crystal on aspiration, and if cyst is infected, then purulent material can be obtained on aspiration. Histopathologically, dentigerous cyst is lined by stratified squamous epithelium containing fibrillar keratin in the lumen, and bilaminated eosinophilic amorphous hyaline-like Russian bodies are present in the lumen, along with the cholesterol crystals are present. The treatment includes marsupialization, enucleation of the cyst, together with removal of unerupted teeth, and this permits decompression of resulting in decrease in size of the bone. Then the second one is the odontogenic keratocyst. It was coined by Philipson in 1956, and it has very high recurrence rate. It is a developmental anomaly which arises from odontogenic epithelium, dental lamina, and basal cells from overlying mucosa and enamel organ. The clinical features are pretty much similar to that of the dentigerous cyst, with more predilection in mandible as compared to maxilla, and male predominance is seen in second and third decade of life. Then radiographic features are unilocular or multilocular radiolucency is seen. In early stage, unilocular radiolucency with well-defined sclerotic border is seen. And as the OKC expands, it causes severe resorption of the bone, resulting in multilocular radiolucency and soap bubble appearance. The contents are dirty white or off-white material. On aspiration, stiff fluid has large amount of exfoliated keratin squamous. The histologically, epithelium lining is very usually parakeratinized with uniform thickness of 5 to 8 layers of cells, and basal layers are tall, columnar, and nuclei are polarized, giving dome-shaped appearance. Connective tissue shows satellite cells or daughter cyst cells, which have high recurrence rate. And because of the daughter cells, high recurrence rate is seen. So causes of high recurrence rate, as I said, because of the daughter cells or the satellite cells, high recurrence rate is seen. Then tendency to multiplicity. Cystic lining is very fragile and thin, making it difficult to remove in one piece. Or if any piece of the cystic lining remains during enucleation, it will result in reoccurrence. Epithelial lining of keratocyst have intrinsic growth factor, which results in regrowth or reoccurrence of the cyst. And cyst can arise from basal cell of mucosa. The treatment includes enucleation of a small cyst, and marsupialization followed by enucleation should be done for a large cyst or a cyst which is less accessible. So again, now the radicular cyst. This is also very common cyst, and it is apical periodontal cyst associated with the roots of the non-vital teeth. It is the most common odontogenic cyst, followed by dentigerous cyst. Etiology includes the dental caries, fractured tooth, and thermal and chemical injury to pulp and iatrogenic pulp injury. So initiation and progression includes dental caries, which converts into chronic pulpitis, resulting in pulp necrosis, and followed by periapical granuloma, which enlarges to become a cyst. Clinical features include male predominance in third and fourth decade of life, and it is usually asymptomatic, with the pain if associated with secondary infection, and temporary paresthesia may occur. Radiologically, round or pear-shaped or oval-shaped radiolucency is seen, outlined by narrow radio-opaque margins, and treatment includes enucleation with primary closure. Now, management of this cyst of the jaw includes enucleation and marsupialization, and basically these two methods are done. For the smaller cyst, enucleation is done followed by packing, or enucleation is done followed by primary closure, and enucleation may be done followed by primary closure and then reconstruction or with chemical cauterization. Marsupialization includes pass 1 and pass 2 steps, and this is basically opening pass 1. In this, a small opening is made, and the compression of the cyst occurs in this, and in pass 2, when the cyst becomes more accessible or smaller in size, enucleation of the cyst is done, followed by packing of primary closure or packing, which will lead to healing by secondary exposure, secondary intention. So this was about the cyst. I hope it was helpful, and we will discuss another topic in next class. So thank you for now.